So good evening everyone and welcome to this month's powwow. This month's topic is pediatric ophthalm, and now I call upon Sumita Garkar ma'am to introduce our presenters and our panelists.
So it gives me great pleasure to introduce two of the fellows who are in many ways better than me now. So Akila passed out in 5 years back maybe, and she is now heads the pediatric ophthalmology at Arvind Chennai, and Akshaya also is somewhere in her compatriot and is doing great job at Agrawal's at Crumpet, if I'm right. So it gives me great pleasure to welcome them both, and thank you both of them for agreeing to do it at a really short notice, and I'm thankful for that. With that small introduction.
Thank you for the introduction, ma'am. So case 1 is a 9-year-old female who presented first in 2019 to us with defective vision in both the eyes for distance. There was no history of prematurity. With regard to parental myopia, one parent was myopic and she had no siblings. So after cycloplegic refraction, in the right eye, the refractive error was minus 1.5 sphere and with 0.75 sil. And in the left eye, minus 3 sphere with 0.75 sil, improving to 6/9 in both the eyes. Rest of the examination was normal. So this child was prescribed with single vision glasses, and myopia precautions were also explained in detail. So this is the spherical equivalent progression chart of this patient, of this child. So we have been following this child till 2025 July. So as you can see, in the first year in 2019, when we first saw her, the spherical equivalent was 1.8 and 3.3 in right and left eye respectively. Though we counsel the patients to come for regular follow-up every 6 months, this child presented only a year later with a significant jump of spherical equivalent to 3.5 in the right eye and 4.25 in the left eye. Again, she was just asked to change glasses. No myopia progression management was started at that point, and she was again asked to follow up after 6 months. But again, patient turned only a year later. So in 2021, her spherical equivalent in the right eye was 4.5 and in the left eye was 5. So at this point, we counseled about myopia progression management, and the child was started on 0.01% low dose atropine. So normally when we start 0.01%, we call them after 2 weeks or 1 month for a review to see if the child is comfortable or has any glare issues. So same way, this patient was called after 1 month, but this patient again didn't turn up after a month. So it was only after a year that she came for follow-up, and again at that visit, the child had not used atropine. So it was only for 1 month that she used atropine, and then again she was only continuing glasses. So as you can see, there was again progression in 2021 June, and despite repeated counseling, still the child was irregular with low dose atropine, and at that point we had no other option left apart from low dose atropine. So as you can see, there has been significant progression, and at last from somewhere around 2022 to 2023, she was regular with low dose atropine. As you can see, the spherical equivalent also remained quite stable. But again, at 2023, this child discontinued LDA. But that time we had the option of myopia control lenses in hand. So we counseled the parents and then switched her to myopia control glasses. So this was in October 2023. And subsequently, after the following visits, she was using myopia control glasses, but still we can see some minimal progression in one eye. So, and again, that is something we find come across with patients who are on myopia management strategies. Sometimes there is asymmetric progression, though there is no significant anisometropia to start with. So this is the axial end profile. Again, you can see in the initial visits, the documentation was not regular. Only in the later phase, we started documenting axial length regularly. So this was in the last visit in 2025. The child was 16 years and is in 11th grade with right eye spherical right eye myopia of minus 6.5 diopters and left eye minus 6. And compared to the last visit over 10 months, there was zero point 0.5 diopter progression in the right eye, and in the left eye, it was stable. So this was with myopia control glasses. So what we noted in this case was that though 0.01% low dose atropine was effective, progression occurred because of non-compliance, and then we had to shift to myopia control lens. So this is the first case. So I have the questions in the end. This is the second case. This is a 13-year-old boy who presented again with defective vision in both eye for distance and was on glasses since 1 year. No history of prematurity. One parent myopic, one younger sibling not screened so far. And this was a glass power that he was wearing, minus 2.75 sphere in both the eyes with 0.75 sil. And this was checked 6 months back with proper cyclorefraction. So in this visit at our center, again after cyclorefraction, we found there was a significant increase in the spherical equivalent, especially in the left eye. The right eye was minus 3 diopter sphere and left eye was minus 4. Anterior segment and fundus examination was normal. But on further evaluation, he was found to have intermittent exotropia also. It was a good control IXT. The stereopsis was excellent with 60 arc seconds, and measurements were 20 prism diopters basin for distance and near. His Newcastle score was 0, and other BV parameters were actually within normal limits. So this child was prescribed glasses, asked to change the glasses, and then started on low dose atropine, 0.01%. At 1 month follow up, he did not have any significant glare, and then was advised to come for follow up after 6 months. So as you can see here, the AL by CR in the first visit was 3.28 and 3.35 in both the eyes respectively. So he was, after starting on low dose atropine in the subsequent visit, that is after 7 months, the cyclorefraction was the same. There was no progression. Axial length alone, again, there was no significant change in the axial length. And AL by CR also was pretty much the same, 3.35 and 3.34. So my questions to the panelists with regard to both these cases. In the first case, actually, myopia management strategies could have been done more effectively had the child been more compliant to low dose atropine. But now at 16 years of age, when the child is still having high risk for more prolonged near activities, still myopia management strategies do they have a role after 16 years of age also? And if a child is on combination therapy with both low dose atropine and myopia control lenses, which to withdraw first, like whether to taper and stop low dose atropine and continue MCL and then slowly withdraw MCL, or is there any other way? Third, the role of low dose atropine and myopia control lenses in children with good control IXT and myopia progression, because we see that a lot of children with IXT myopia is more common in children with intermittent exotropia, and there are a few patients where we have started on myopia control lenses also with in children who have good control IXT, and we see that it seems to work. The progression is under control in these children. So I would like to hear from the experts on the role of low dose atropine and the myopia control lenses in children with good control IXT. Thank you.
Before we go on, Jitendra has joined, so let me quickly introduce Jitendra. Jitendra does not need introduction actually, because he's one of the leading figures in myopia research in India, having published several land-breaking several studies, and he was one of the earliest converters to low-dose atropine, and I think he started kind of dispensing atropine, making his own formulations and he was, I think, one of the first to publish effects of low-dose atropine. So I don't have to stress on his credentials as being his credentials in being a panelist in this session. He knows all what is there to know about atropine, and he comes with a refreshing perspective, which is while he was rooted in the institutional practices, but he also is a private practitioner and a researcher at that. So his perspective comes from a little different place than, say, mine or somebody who is very much into institution. So it is a pleasure to have Jitendra here. And Jitendra is also, let me plug Jitendra for one more thing. Jitendra is also fantastic for his own ARC member. Please, all of you, those who attend, are attending or listening or will listen later, I would sincerely request you to
Thank you so
vote
much,
for
ma'am.
him. Request to vote for him. And yeah, with that, now I think we can go to excellent questions which she has put up. So I think first question was whether to continue atropine beyond 16. Yes, Jitendra.
Uh, Actually, madam, I think when we talk about, so in case number one, when we saw that we removed atropine, and there was a small progression in the right eye, not in the left eye, but in the right eye there was a small progression. When the glasses were introduced and atropine was removed, that probably was because of the rebound. So once you are removing the patient from atropine, there's a good chance that patient will have a rebound. 16 years of age, and given a choice between drops and glasses, obviously, if the patient is affording drops, always suffer from the fact of the fact that you have to put it every day. So obviously, compliance is a huge issue, and this has been discussed repeatedly that bulk of the reason why atropine doesn't work, or bulk of the patients actually are not compliant. So it is not that atropine is not a good drop, or glasses are better than atropine. The only thing is that compliance is a huge issue, and probably, and in your own the first case, we saw that compliance was the issue even when patient is, so even if patient is compliant for 80% of the time, for clinical purpose, we do believe that that is almost like 100% compliance. So between glasses and atropine, the glasses always will score when it comes to compliance, because patient has to wear glasses to make sure that patient is able to see. So the control will always be better with glasses. Now, at 16 years of age, obviously, if it is a progressive myopia, we can definitely go for glasses. The good thing is that there is not much of rebound with glasses. With atropine, at any age, at any point of time, rebound is pretty common. Even with the tapering, a rebound has been noted, at least in whatever work we have done. We don't have a huge series, because I think now, only now in last couple of years, we have some patients in whom we are trying to stop atropine. So we don't have a huge experience. The number of patients are not much, but tapering doesn't really change the course, at least in a very small subset of population. In my personal experience, we have not published it. We were trying to assimilate the data with Dr. Aditya and Mihir, but in a very small subset of patients, we did not find that tapering made a very big impact. At which one to stop first? Again, if the patient is affording using glasses, obviously we would remove atropine first. Also because glasses are there to take the damage of rebound, so we would try to remove uh, atropine first. For intermittent XT, I would like to quote Mihir's paper, which he published for in IGO. He had presented three cases in which post low dose atropine in the intermittent exo patients which they had operated, patient developed esotropia, and on stopping the atropine, patient became orthotropic. And I think there was a case in this year's IMARC at LVP, where one of the optometrists, I think, presented a case in which atropine was given to a patient and patient developed esophoria. So in an intermittent XT patient, I always keep saying that even if there is a very small chance that this would improve, uh, the fusional amplitudes, not improve, but sort of stimulate the fusional amplitude, because we know the pathophysiology would be that when you give low dose atropine, the accommodative effort does not completely go, and patient has to put a higher amount of accommodative, just like a low AC by A ratio kind of patient who develops esotropia. So in an intermittent exo patient, if we give atropine and patient develops a low AC by A ratio and tries to accommodate more, and thereby some convergence is induced, and that helps in intermittent XT. then why not give low dose atropine as a first choice? So that was regarding the three questions.
I think there is very little data available on large series is not available. Whether conventional wisdom has been because you are using a defocus, peripheral defocus, it will worsen your control you because you are inducing a worsen. So I think there has been a little bit of a mm, when it comes to glasses with intermittent exotropia, there has been always been a little bit reluctance that this peripheral defocus will induce, but actually, evidence is pretty thin on
Very true. Very true.
whether it makes any real difference. So sometimes, if I feel that compliance with the glasses has been poor, compliance with low dose atropine has been poor, even with children with exophoria or little intermittent exotropia, I have given them glasses. But
Yeah, yeah.
what we should probably collate the data in the sense that you should look at accommodative parameters and maybe use an NCS score to see if it really worsens or is it just an anecdotal feeling that you have. So,
So as a first choice, I mean, given between atropine and glasses, what would be the first choice in a patient of intermittent XT?
Sir, Dr. Akshaya here. I just have a doubt, sir. So did we taper the low dose atropine over how many years or how many months? Is there
So
a
in our practice, since there was the bulk of the studies in lamp and atom, they have not tapered it; they have abruptly stopped it. So there was no precedence how to taper. So I think most of us have. So one of the common drops that we taper off the record is steroids, and so we learn from whatever we do in our in other things. So what we did was that if the patient was putting atropine twice a day, we would put it once a day for at least 1.5 months, and then we will tell them to put it alternate day for 1.5 months, 4 weeks, and then we will tell them to put twice a week for 4 weeks, and then tell them to stop.
okay, sir? And
So
what about yes,
that
sir,
was the
yes.
tapering schedule.
Okay, so what about a BD dose if the OD dose is not
For that, I
working?
am a very big fan of it. I mean,
yeah,
I use BD
yeah.
dose very
I think
frequently. I have been a
I
I
think
have been a very early proponent of BD dose, although I have been criticized multiple times that BD doesn't mean it will increase the toxin. Everything I agree with that, but I have been I have a different take on that BD dosing. So what happens is, and I think I was discussing with Madam also in PSN that when you tell them to put BD dosing, at least they are putting once a day.
once a day.
So I think what is happening is that probably it is not the BD dosing, but it is increasing the compliance. Somehow it is trying. We are trying to accumulate the drug, and that is working. It is extremely difficult in these situations where you tell them to put twice a day to to really monitor the compliance. And I think we were one of the few people who actually published on compliance also, because we had a letter to editor in IGO on compliance, and it was not very great. I mean, almost 14 to 18% did not comply at all.
Okay, sir.
And to us, we considered, even if they put 75% of the times, we considered that they are doing it 100%. Even 70% of the compliance was taken as 100% of compliance.
So just one more thing about a thing about the atropine. In one of the messages, Dr. Pradesh Sharma sir had said you can even put in the night itself twice for a BD dose. So
So I will tell you this: where has this come from? I think there was a discussion going on somewhere. I think on WSPOS or somewhere, where the question was asked to Dr. Yam, and he said that instead of putting it twice a day, you can put one drop, and then after 10 minutes put another drop. So that is you are increasing the concentration.
okay, sir.
Uh,
So it,
you can I mean that was what was suggested. There is no formal work on that. Twice a day, incidentally, we have presented that at AIUS. Publication sometimes take longer. It is still in IGO since last 7-8 months. It is still in IGO. We tried to publish it, but there has been I have read at least 3 articles where they have compared twice a day with once a day, and they said that twice a day was definitely better than once a day.
So we have a thesis on Dr. Kayalvuri's thesis is there on
Yeah.
twice a day
So
I don't know if Dr. Akila is there in the meeting, but she was the guide for that meeting. And again, we looked at people who were not responding enough with once a day. We have looked at their progression rates between once a day versus twice a day, and it did show promising results. That so. One more question I have for Jitendra. If
yes,
you
sir.
are going to do what are your strategies to compliance? Do you call the patient? Do you send them reminders, or is there a way where you can improve compliance? Because all said and done, it is still the most affordable myopia
True.
intervention available for a large number of patients and easily available in even in smaller
Yeah.
towns. Is there a way where you can kind of monitor, more than monitor, improve the compliance?
I think
Do you-
there are two things in this. One is what we can do, and one is what I mean socially we can do. If we sit with the patient for a long time, which is possible in private practice, so we don't have I mean, you can call the patient on a day when you know that patients will not be much. That is typical private practice. Like you call them as around like in the evening or on Wednesday or on a day where you know that you don't have many patients, and you can sit and sort of scare them that myopia is progressing in their kid, and that increases the compliance. Another way is to that there was an article that you can put 1% atropine twice a month.
does it
I
work?
don't know. I don't know whether you have heard of that, but one
Yeah, but
percent twice a month.
yeah, that sounds very good.
So that increases the compliance. I mean, that is another way of what we can do. It is like penalization where we do twice a week. Here they are saying 1% atropine twice a month. So
Maybe once in a week probably will be all right.
give and take है madam. जैसा मतलब whatever way is convenient. But once a month, once a week is also a good idea. That would definitely increase the compliance, because that way you can even call the patient once a week to the clinic and put the wonder drug.
Yeah, that
Actually,
I've not.
yeah.
Yeah,
Yes, ma'am. Actually, our PG thesis was also on compliance to low-dose atropine, and we published it in IJO same. But the rates were slightly better in our study, maybe because we give a logbook to the parents, so under parental supervision, they'll just have to,
log in.
uh, yeah, log in
Log in.
whenever they apply the medication. So the rates were slightly better, and we also saw that in lower socioeconomic groups, the compliance was slightly low. So maybe again, it comes to counseling part. Uh,
The good thing is that low socioeconomic class has less prevalence of myopia also. So
and
that's another aspect.
I have one more question. And thank you for your inputs with regard to my cases. And one more question is like, do you come across asymmetric progression or unilateral progression? And how do you manage these patients? Like we see both the eyes being myopic, but progression in one eye.
Yes.
Do you tackle it in the same way? Like how do you see both eyes progression,
I don't
bilateral
think there
progression?
is much literature or much understanding why it happens. I mean, once we have a little bit of more understanding why it is happening, it would become much easier to deal with it. Right now, it is like this is what has happened. Just now, I saw one case where one eye had progressed and other eye had not progressed at all, and this has been when it happens consistently, the anisometropia becomes quite a lot. I don't think there is much of reasoning why it happens. There was some initial thought process that it is because of the head posture and probably child is looking from one side, but it is very hard to believe that consistently he is doing it. without having any sensory adaptation or without having any advantage as to why he is doing that. And I think Kaushik has presented his work in AIOS. Kaushik from Shankara, Bangalore. Yes, he has presented that head posture doesn't, at least in short term, it doesn't change much. I mean, it doesn't change either eye strain or NPC, NPA, binocular parameters, or even I did not, I don't remember the entire paper, but in essence it meant was that head posture doesn't really affect myopia progression. So that also doesn't fit into why some children progress asymmetrically.
So what about very close work? Like children go very close to the book and
Yes.
right side mostly, because in anisometropia, I don't know. I've just seen a lot of right eyes being more myopic. I mean,
See,
This is
there
a
is a
little odd because generally everything else is more in the left eye. This is the first time I'm
the
hearing.
no, ma'am, the right-handed children with very close work, like
They will
Yeah,
tilt their
but
head
that
also.
is very natural. See, the point is there has to be cause and association. I mean, cause and outcome. Most of us who are right-handed would try to tilt our head towards the right because your hand and that particular side is closer. Obviously, because you are right-handed, so you will be like this. That is natural, but it doesn't happen in all the patients.
yes, sir,
It is
for the
not that
progression,
frequent.
for the
Yeah.
AHP and the progression.
No, that is what I'm saying. So the progression should always be slightly more if the patient is right-handed in the on the right side. So it would be very easy to catch those patients who are left-handed because the number of left-handed patients are very less.
Got it.
But it doesn't happen.
That way.
It doesn't fit entirely into it. You
Okay.
are see the current theory and understanding is this only, that probably they are doing it like this and they are going closer from one of the sides, but in reality it doesn't happen in all the patients, because all the patients will have some this thing, either they will be towards the right, towards the left. And it's actually a very good paper. The Kaushik Murthy's paper is a good paper. He has shown that when you tilt or what actually happens, they have tried to address it. I think Soumya is also one of the co-authors. So I used to talk about a lot about that maybe head posture is affecting, but once I heard their paper, I felt that probably something else should be responsible.
Okay.
But there is not much of evidence as to what is wrong there.
And not every child actually tilts also, no.
Ha ha, not every child progresses also.
Close, ma'am.
Well,
Close work, ma'am.
Yeah, so there are a fair amount of people. So I think it's probably anecdotal at this point to say ki this is reason, but there could be a truth, kernel of truth into that in some patients. Any other questions from the audience in chat box or my Shikha or anybody?
One question if we have time.
Yeah, sure.
Yeah. I mean, the role of peripheral refraction now, like in our center, we don't do peripheral refraction. At this point, like whether peripheral refraction still has a role, whether does it change your management strategies?
I will give you a simple answer. In all the studies which have come out with different myopia progression lenses, there is never any mention of peripheral refraction data. So either those studies were underpowered or they did not find anything. I'm sure this data was captured. I'm sure this data was captured, but none of the results, whether it is Essilor or Zeiss or Hoya, none of them have put out that data in the papers which they have. They are also only looking at SCR versus exit length, and they did not really say that this was more effective in certain patients who had peripheral atropia versus it was less effective. This data has never come out in any of the papers. So either it did not, because I find it hard to believe that they did not capture that data when they were looking at those children. So if they have not put it out, probably it did not make any difference. Regardless, it was effective in every. That's my personal take on it. Jitendra, you have anything to add?
I think, see, the issue is uh, whether there is peripheral hyperopia or not, we are creating peripheral myopia, and it is working regardless. So again, the problem is uh, we have found out the solution, but we don't know how it is
How
working.
it is working
Uh,
exactly. So I
so,
don't.
with all due respect to Earl Smith's research papers, starting from 2007 to 2016, I think he has published bulk of the work is from University of Houston, and they have done tremendous work. The problem is they have they have proved that it is the paramacular area or parafoveal area, but nobody has been able to tell which part is really responsible. There was a recent article in which they said that it was between 9 to 12 degrees. And most of the glasses that are available
And
will touch only after 25 degrees, because you have a central clear 9 millimeter zone and you have to have that. Otherwise, how will you see? So your normal vision will get impaired. In dots lenses, it is 5 millimeter. That is, we have not used it's only one Cypress trial is there, but it doesn't work on peripheral defocus. It works on a separate contrast mechanism. So
that's
if
some
we talk
kind of
about,
on-off mechanism, right?
yes. So if we talk about peripheral hyperopic refraction, even Dr. Jyoti's work, or even Dr. Pawan's work, they have suggested that there has been asymmetry between nasal and temporal part. Dr. Jyoti was today only in module 2. We were talking about the same thing, and she said that there were patients who actually were peripheral, having peripheral myopia rather than peripheral hyperopia, and still they responded to peripheral myopic glasses. So I don't I don't know how. I mean, even if we do peripheral refraction, whether it would help or it would confuse us further. I don't know, and that is why probably I could never invest in a open field autoref, because it will just tell you peripheral refraction, and you may think that he is peripherally myopic, and you may not give glasses, and somebody else may give glasses, and it may still work. So,
There are two questions in there. I don't know if they're directly related to the case, but I'll read them out. It's since it's an alumni group meeting, I'd asked them to post their questions. First question actually is by Dr. Salil, and Dr. Akshay has kind of answered it. He'd asked about orthokeratology. I had just posted that question, what's its role, and he wanted to know whether it permanently changes the corneal biomechanics. And I think Akshay has answered. You can also answer
No,
that
I
question.
what I think orthokeratology. I think Akshay is presenting a case on orthocare. So
So
let
maybe at that time you can. And
we
the
can
other one is by Rishikesh. She is asking that in SN, has anyone done biometric study in lasered ROP kids with myopia?
we do have biometric data available for these children, and in my experience, again, not really collated the data, but in my experience, a lot of these kids start with really high myopia, but
Yeah, that's what he
they
is getting.
usually don't progress that much unless they are teenagers. But there is a subset of these patients who do progress like axial myopes later on, little later on. But my question again here is ki, after all your myopia progression information is so that you restrict a large number of children to mild to moderate myopes. But if a child who is already minus 12 and then progresses to minus 13.5 over a period of 5 years, does he require intervention? I have not been able to answer this question to myself very cleanly or on any evidence basis. So, jury is out on that. Jitendra, you have any thoughts on this?
no, madam. It's. I mean, see, it's all. It's more of a protocol-based thing. If you have an option, and if parents want it, you can do it. वैसे भी about 12, you don't have the option of glasses because the upper limit is 12 diopters. And in my personal experience, low concentration, low dose atropine doesn't, it is too low to make a difference at such a high myop. Although I remember there was a publication in IGO, uh, Muzaffarpur district or somewhere, I don't remember, but there was an article on high myopes where they had used low dose atropine, and for them it really worked.
Thank you. Thank you. You can proceed. Thanks for answering the questions.
I think we can move on to Akshaya's presentation, and then we can continue here, because I think there will be some questions about 0.05.
So this is a case of a 7-year-old male who presented with complaints of diminution of vision in both eyes, which he had noticed for the past 3 months. He had no other history of wearing glasses previously, nor did he have any eye exam itself done before. He was a full-term child with no developmental delay. No other ophthalmic or systemic history was positive. His mother was wearing myopic glasses from childhood, and on examination, he his vision in the right eye unaided was 3 by 60 with pinhole improving to 618, and near vision was N10. Left eye it was 6 by 18 improving to 69 N6. So the dry refraction was minus 9.5 with minus 1.5, with which he was reading 6 by 18. And his with a little bit of add, his near was improving to N6. Left eye it was minus 2.75 with a cylinder, he was improving to 69 plus. His dilated retinoscopy, cycloplegic refraction was slightly lesser in the right eye. And examination of ocular examination and fundus examination was within normal limits. And on cover test, unaided, he had a flick IXT to RXT to exophoria for near in the in the unaided state. Stereopsis was 200 arc seconds, and the lag of more than +1 was seen in the right eye. The left eye, there was no lag. And on checking his axial length, it was 28.37 in the right eye, 25.67 in the left eye. And vitreous chamber depth was also quite long, which is 20.82 in the right eye and 18.21 in the left eye. His K reading was 41.5, 42.3 in the right eye, and 41.7 and 42.5 in the left eye. And he's a clear-cut case of an axial myopia. And in summary, this is a 7-year-old child who's full term, whose mother is myopic, and he spends more time indoors with almost nil outdoor sunlight activity. He's an anisomyope. He has refractive anisoamblyopia, and on binocular vision parameters, he had lag of accommodation. So, what are the points that we had to address in this was to correct the refractive error, treat the amblyopia, and treat the lag which could possibly be a cause of that unilateral high anisomyopia, lifestyle changes, and then myopia control measures. So we thought of having two different approaches. One is a step-by-step approach wherein we first correct for vision and then correct amblyopia and then go for a control measure. And then, or we, because the child is very young, 7 years, anisomyope, and his mother is a myope, and his lifestyle changes are not, visual lifestyle is not so good. Can we try to address everything in one sitting? And if we leave the amblyopia and anisometropia, not addressed, it may cause worsening of his IXT also. And of course, without a proper control measure, he may keep progressing. So we thought we will give him glasses for correction. But if the correction will also again have only anisometropia, and he may not be using the right eye. It may not help in his IXT and anisometropia. So we thought we'll first do ortho-K in the right eye, see how much the ortho-K is correcting, and balance the anisometropia, and then give glasses for the balanced prescription. So what this addresses is the anisometropia as well as some kind of control measure in the right eye, and then treat the amblyopia by patching. And because he had a lag in the right eye, and with add he was improving to N6, we thought the balanced prescription can have a bifocal in the right eye with a plano in the left eye, and of course with lifestyle changes. So first we did the ortho-K parameters for the right eye. So his vision unaided was 3 by 60, and with a over refraction of -2 at 40, his vision improved to 6 by 36 with the ortho K. And so this is the pre-ortho K topography of the tangential anterior curvature map and corneal thickness. And this is the anterior elevation and posterior elevation before ortho K. And post 2 weeks of ortho K, his vision had improved from 3 by 60 to 6 by 36 with the ortho K, and the over refraction was -3 with -1, with which he was improving to 618 and N8 to N6 with strain. And of course, left eye we did not try ortho K. Only to balance the anisometropia, we gave him ortho K in the right eye. And this was post ortho K 2 weeks. The right eye tangential anterior curvature and the corneal thickness, and anterior and posterior elevation. And post 3 weeks, his vision had further improved, and the compression effect of ortho K was more. It had come to -1.5 sphere with a -1.5 cylinder, and his vision had come to 6 by 18. And with an ad, he was comfortably reading N6. And the other eye was again 2.75 cylinder. So we gave him ortho K in the right eye and this prescription for the over ortho K glasses. And then we also gave him patching for the little amblyopia that he had. So, so this was the plan. So ortho K was given in the right eye for myopia control as well as managing the anisometropia. And bifocal contact lenses over the bifocal glasses was given over that to treat the lag, which probably was the cause for that unilateral amblyopia. And we continued patching. So once the amblyopia becomes better, probably we thought we'll switch him to a control glass over the right eye ortho K. So this was a kind of a synchronous approach we thought, because first of all, the child had high risk myopia, and so we started the control measure straight away without waiting to look for a progression. So I just wanted the expert opinion on this. Um, so since we are doing a lot of ortho K here now, we sort of thought we could, start off a synchronous approach like this instead of waiting step by step to have the anisometropia sorted and then amblyopia sorted and then the myopia control. So just wanted to have an opinion from the expert.
How much was the anisometropia? Can you go back to the slide?
Yes, ma'am. Yes, ma'am. So yes, ma'am, 9.5 with 1.5.
6 diopters.
Yes, ma'am, 6 diopters.
I can only say that it's one approach. This, but I think he would have done equally well with it.
Sorry, ma'am.
I'm just saying this is a good approach if you have patient who is compliant, and it's a different way of thinking the way what you have done. I have no disagreement with that, but my feeling is that he would have done equally well with just single vision glasses, patching, and then
Control measure
later. Yeah, this is what I would have done.
And because he had a lag, like he was better with ad and all, I was little this thing about giving low dose atropine. Otherwise I would have just taken the conventional approach also.
Yeah, I mean, lag you can always give bifocal glasses, but you could have given, I mean, you could give glasses.
Lag is not much. Lag is just one diopter, which is
no, sir, it was more than one. It was about
slides. I thought I saw it was one, but maybe it was more. I didn't realize. I think you had written lag was +1 diopter. Yeah, more than +1.
So here, how we are checking lag is we have a plus or minus one, +1 flipper, sir. So the moment we have a width reflex in that +1 in dynamic retinoscopy, we consider that as a lag. We have that +1 as a red flag for the lag. So we don't exactly measure how much lag, but with an ad, he was clearly reading better for near.
So maybe he had a accommodative issue itself. High myopes are known to have some accommodative issues also.
Okay, sir.
See, lag is when you're at least your accommodative effort or accommodation amplitudes are normal, and still patient is having lag, no?
Actually, we've done an accommodative flipper for him. I've forgotten to mention it was only 4 cycles in the right eye, 12 cycles in
Okay.
the left eye.
Maybe
So I
if
think
we
he's a little less
even
accommodated.
amblyopes are known to have a little bit
Yes.
of poor accommodation, and we could then give him some exercises for accommodative facility. I mean, my point is that putting your treatment purely on the basis of lag, and if we are giving ortho K, why not give him a soft contact lens itself?
Ortho soft contact lens is a 7-year-old boy, so he has to wear over the day. Ortho K, he just has to wear it on the night, and because we have some patients who are comfortable and all that, we have started giving Ortho K now. So
No, I do give ortho K, but I am always, I mean, above 8 years of age. But then I don't think age is a important criteria for anything. It all depends on the understanding of the kid. At 7 years or 8 years, it is the same. My point is that if we are giving a contact lens, normally soft contact lenses are more, you know, more easier than compared to a RGP lens and a bulkier lens, which is ortho K. But as Sumita madam said, it is you are right. I mean, this is one of the approaches. And why not ortho in both eyes then?
cost, sir.
You can give in one eye, you can give in two eyes also.
So 2 eyes comes to 40K almost.
40K
That's
is cheaper.
that's right. I mean, 40K is to the doctor, madam, or to the patient.
40K to the patient.
Acha.
I thought 40. It's a little bit more than 40K.
But even if see the point is that if you give ortho K in both the eyes, then he's purely glass free, purely free of all kind of myopia control, because then ortho K finishes everything for us, and even right eye can have toric ortho K, and then I
I
mean,
think his power is around
9.5 with
but
9.5. So to be
madam, they could get very good result. No, only 1.5 is remaining post
yeah, but
ortho K.
that may not be enough for a school going
Actually, we
child.
never thought we'll end up only with a 1.5, sir.
No, if you give a tight lens, you can end up with a, and ortho K is also, accumulative. If you keep on wearing, it will keep on flattening the cornea.
Okay, sir.
Obviously, it won't become concave. It will only flatten the cornea, but it is additive also. The more you wear, the more
Static.
effect comes. Sometimes they make modifications. They give you one lens, and then once it is flat enough, they give you even more tighter lens. So first they will give one day after flattening. Like if the cornea is 45, they will give 44, and once you can achieve that much amount of flattening, they will give even lower, even flatter than that. So that is how they do it in patients who have got more than 6 diopters. Normally ortho K works very well till 6 or 6.5 diopters, but you got
That's
a
why I
very
think if you leave him with 1.5, again you are creating a blur, leaving with leaving without glasses in the daytime. If
So
you
that is why we retain the glass in the other eye also. And also, sir, just another doubt here. So a lot of ambliopes, like, they read better with ad. So if you're not reading N6 and we just give the distance power and give patching, does it really work, sir? This is just not for this case, generally for amblyopia.
So for those ad, I have, I mean, I'm not saying that this is published, but I have a theory that that ad actually helps them for near because it magnifies the image also. So if you tell them to bring it more closer, maybe they may be able to see N8, and otherwise the distance vision is going to reflect in near also. So an emblyope should not be able to read N6 for near. If he is not able to see for distance, why should he be able to see for near without ad?
Okay.
Obviously, without ad, he should not be able to see. I mean,
So
the
it's
near vision
so
and distance vision
lot of
mimics each other.
So are we justified in giving the ad for amblyopes and people with high myopia lag and all that, sir? Like a bifocal or something?
no,
With
I don't do
intermittent
it for
XT,
everyone.
with intermittent XT, it may actually worsen the exo because the lag is there, but that is also inducing the accommodative effort. So if you relax that accommodative effort, there's a possibility that for near they may go more into exo, because we are giving an ad for near. And I honestly don't personally don't do that.
Okay.
I don't do that in my practice, because a lag up to 1.5, I have seen it really doesn't create much of. And I started seeing lag only because of myopia.
Okay, sir.
Previous to that, I never used to measure the lag. And up till 1.5, a lot of patients have a lag of 1.5.
Okay, sir.
See, if you actually look for binocular abnormalities in facility, hypoaccommodation is a lot more prevalent than the patients present symptomatically. So if you are going to look at school, if you look at Rizwana's work, some humongous amount of 10% or 20, 11 or 12% children in her school screening data had binocular abnormalities like accommodative lags and infacility, which was the most common, the accommodative infacility. So amblyopes, if are you if you are looking at adding a ad for an amblyopic patient purely, I think it is not justified. Give closer to their full correction. I would
Sorry,
give.
ma'am, I couldn't hear you.
No. I said if you are giving a addition to support the accommodation, because a lot of amblyopes are also hypoaccommodative,
Yes.
it makes sense in a small percentage of patients whom you want to give. It is not something which you do it on a regular basis in every patient, because they may have some hyperaccommodation, but they are not that kind of lag where it needs the addition. Yeah, in your case, you said it was more than 1.5, but I agree with Jitendra. Even if patient is having a lag of accommodation, it is rarely going to be more than 1.5, which requires the addition of a near ad. Even in an amblyope who is not myopic, I am talking about purely as an amblyopic patient. So that's why when you start them with glasses, sometimes you try to give them closer to their full correction. Let's say you have a strabismic amblyopia and patient has 1.5 plus 1.5 with some cylinder, and you want to give that 1.5. Adding that closer to their full correction often helps in amblyopia. You don't have to give ad each time. We are diverging from this, but I'm talking about addition of a plus lens in a amblyopia, not in your.
Okay.
So don't cut in a normal normally we say cut 1.5 or cut 2 when you're prescribing glasses. Don't cut 1.5, cut only 1, cut
Got
only
it.
or cut only 0.5 to start with, and then
Got
as
it.
their vision improves,
Mm.
you can.
Understood. Mm.
Yeah. So I'm talking about general amblyopia. I'm not talking about your case in particular where there is no reason to cut anything.
Understood, ma'am. Mm.
Yeah, but I would not have added ad either in this
Okay.
patient. He would have improved with glasses, patching,
Okay.
and
Mm.
then you could have looked at myopia control as a second step.
Okay.
You did it because probably a mother was anxious and did not want it. I'm not saying that. I'm okay with the approach, but he probably would have, just for public to listening. Your way is one way. There is also a traditional way of doing things also would have worked equally. That you just put the glasses, patch, let the vision come up to normal, and then worry about it. So that's also perfectly reasonable.
Got it, ma'am.
Also, ma'am, the stereo acuity of this patient is pretty good. I mean, there's a
Mm.
very good prognosis that the patient
It
would
will
improve,
improve. Yeah,
because
yeah.
even with the first time giving glasses, the stereopsis for near, obviously you have seen for near, it is around 200 seconds of arc, which means that, the kid is able to see binocular
Okay.
and also able to see in third dimension, which means that once we give glasses, there's a very good chance that he would improve. So prognosis is very good because he is able to see binocularly. And these, I'm again deviating from the topic, but these are the patients who are fit for binocular exercises rather than patching. Like patching, obviously, patching works everywhere, it is universal. My first choice in all the patients would be patching. But this is where we can give part-time patching and also can give them exercises, online therapy, binocs or revital and gyroscope. All those binocular exercises do hold very good role in this, because the kid is already able to see binocularly. So there's a very good chance that dioptic stimulation would help in these patients.
Okay. Okay. So 200 usually is the cutoff, sir, for good stereopsis and binocularity. Is there a cutoff like that? This is titmus
Any presence of any synopsis
something.
is a good
Okay.
indicator. Ki there is
200
something
is quite
good.
good. Actually,
200 is
200
very
to
good.
बहुत अच्छा. It is pretty good, because then you just have got 100 and then 60 and 45 and 15. Matlab 200 is pretty good amount of
For a
stereo.
binocular exercise.
Yeah. 200 is pretty good.
If you give by post amblyopia therapy, it will improve also from 200.
Yeah, definitely.
Sure.
So, any other questions? Any other thoughts on anything else, Jitendra, related to orthopedic?
No, I think we can. I mean, if we ortho-K, even in ortho-K itself improves good vision, because the amount of aberrations go down. Because
Yeah.
your power comes
Power.
down, so the optical aberrations, which are because of the glasses, they come down. So that in itself improves one line, at least in what patient we don't have huge experience, because we are also afraid of ortho-K in children, probably because of infection. So we have got only 6 patients in last few years, but all of them are, I mean, their visual quality also improves, mainly because of the fact that their glasses go away. So it definitely improves.
So, we have also recently some ortho-K lenses which were available few years back versus now which are available. I think they are much better quality, and ease of comfort of wearing is, I think, also much better compared to what was available few years back. Ortho-K is not new; it has been around for. In fact, it was probably the first myopia control measure which was ever put in as. Nobody looked at its role in myopia. That's all. But otherwise, Ortho-K has been around for several years. I think newer lenses are more comfortable, easier to wear, more easily available. I think it has a small subset, some niche role in our practices in general. It is still not widely available or widely affordable. Let's put it this way. So those people who are listening in, I think also keep Ortho-K as one of the options in our criteria, because if you are looking at a purely myopia control measure, I think it works the best, but also has the worst rebound when you do get out of it. It works wonders with combination with low dose atropine, but again, rebound. When it comes to rebound, how soon is the rebound? I am not seeing it as these medical reports 6 weeks, but
Ma'am, your voice is not clear.
I was just saying, how soon can you see the rebound in your practice? Is it as low as 6 weeks that you will see rebound after stopping low dose atropine or even any drop or orthopedic? Do you see it
Yes,
as early as 6 weeks?
yes, you can see within 6 weeks.
Because
Thoda bahut
my experience has not been 6 weeks. Is to me looks a little too early. Akila, have you
so
seen rebound as early as
Madam,
6 weeks?
6 weeks. Actually, it is like this. So we put the patient on tapering dose. So actually, when he stops the atropine completely, it has already been 2.5 months. So once he stops it completely, and after that, if we consider 6 weeks, that will already be 3 months. Like we will tell the patient to put twice a week for 4 weeks, and then again call them after 2 months, or uske 6 weeks. So it is already 3 months.
No, because I don't
Yes.
taper it
Acha.
over weeks. I actually keep them on once on alternate day for 6 months. So I have never experienced the kind of rebound which you all report, that it's very early and it's within 6 months. Because my tapering schedule is okay, 3 years of atropine, good control, alternate day for another year.
Acha. Oh.
Then
Ma'am,
twice a year.
what?
So I think there is no standardized taper schedule for anybody. I think the new consensus guidelines are coming up with some tapering schedule, but I think at this point, pretty much anybody and everybody is doing whatever they want to do.
And
What about?
same is what we follow here, ma'am. Alternate day regimen for 6 months. But some nowadays I started calling them at 4 months instead of 6 months, and then stop.
I
Because
think
you will
Avoiding.
not.
what we should try to do is we should try to see when the pupil size starts becoming normal, then we should start to see from that point when the rebound is occurring, because till the pupil size is still slightly dilated, it means patient is still under the effect of atropine. And once that, I mean, that could be one of the ways of finding out from where we have to count the rebound, because we have to have a certain point of time from where we can count. If you give it for 1 year, madam, then then there is no tapering. It is like they are continuing only for 1 year is very long.
No,
There is
I
no
so will keep
taper. It
them
is
at
just that they are putting it alternate day.
yeah. That's why I have never seen any rebound.
But there will not be, because they are like slightly non-compliant patients. They are not really stopping the drop.
No. I officially tell them to put it every alternate day for at least 6 months. I call them after 6 months, and then if they are still stable, then only I ask them to stop, not for a year or so.
So do you see that there is once you start telling them to put it alternate day, do you see any change in pupil size?
I've not
Not
looked
looked
at
into
pupil
it.
size
Looked
because
into
by
it.
the time they
Okay.
come to me, they are already dilated. But yeah, but that is a good observation. I've never, I mean, we never routinely check
Pupil
pupil
size.
size in any. Now, the elephant in the room, 0.05%. What's your thought on that?
Right. Atropine is purely dose dependent. So there is, obviously 0.05 will work any day. It will work better than 0.01. And same goes for its problems and problems of accommodation and problems of it is like, I mean, if it is working better than 0.01, it will work on all the tissues, which means it will work on the iris, work on the pupil, work on the ciliary body, and so near point of accommodation is bound to recede more than what we see with 0.01%. Accommodative lag is bound to increase once we use 0.05%.
And rebound is also going to be more.
So 0.05%, we have 0.01% with us. So once you give 0.05, you tell the patient to switch to 0.01. I mean, I have not done it yet, but that can be a good idea of putting it 0.05, telling the patient to put 0.01 twice a day for 3 months, and then putting it once a day for 3 months, and then putting it alternate day for 3 months, and then gradually come out of it, because now you're sitting at a higher pedestal. So from there you can gradually come down.
There is a little thought about starting 0.05 in younger children and not having that
Yes,
many accommodative issues, because younger children have much more
better
accommodative reserve.
amplitudes.
So, and older children are likely to have more accommodative difficulties and also likely to have more complaints about drops and compliance consequences. Have you experienced that? Are
Yes,
you
yes,
are you
definitely.
still preferring 0.05 for really young children, or you do give it in teenagers also?
0.05 for really young children, 0.05 for resistant cases,
Okay. So
not
you're
responding to 0.01,
not responding to 0.01. So,
and
but
young children both.
yeah, but you will not start them in a 16-year-old like Akila's patient. You will not start a 0.05 in that
No, no, I
child.
will start 0.01 to see whether he is responding to 0.01 at 16 years of age. Definitely, I would like to start 0.01 first. If he responds to 0.01, then I would not switch over to 0.05, because
Understood.
most of the cases at 16 years of age will come back with some complaints
So
with a
you,
higher concentration.
so you will be very, very careful about prescribing higher dose percentage in older children, or at
Yes.
least see them more early. Would you kind of see them a little earlier than the to see the?
So all patients in whom we start atropine, we call them again after 3 weeks, just to see that their photophobia or near point of accommodation, or is there any problem, whether they are comfortable or not.
So you won't change your schedule for 0.05. You will still continue to see them at 3 weeks.
Yes, but we tell them clearly that it is a higher concentration, and if you have any complaint, you come back early. We counsel them for atropine 0.05. Earlier, when we used to dilute atropine and give it to them, we used to counsel them about 0.01% because it was off label. But for 0.05, we tell them that this is a higher concentration, and there is a small chance that the kid may complain of photophobia and a problem with near vision. And if it happens, they should come more quickly. I mean, if there's a problem, they should come back again after 10 days or 15 days. In initial days, we tell them that if they can adjust with that, it is fine. But if they can't, they should come back at 10 or 11 days.
How about your? What are your thoughts about starting combinations straight away without?
I don't, madam.
You are starting with monotherapy, and then only if
90-95% of the cases we start monotherapy only. If there are, and those few patients are actually children of doctors only. Two of them are children of ophthalmologists. They
who
want
have
to
started
start. They want to
combination.
start combination together. They are more afraid of myopia than me also. They are afraid of myopia. So they say that why don't we do it both together? And I tell them, I mean, this is purely your choice. We would do it like this, but if you want to do it, so their point is that we will give glasses, and atropine we will put SOS. Matlab, they themselves know that compliance is poor with atropine. So that is that is the honest truth. I normally don't go for combination therapy together. Bulk of my patients are either on atropine or on glasses, and then we have escalated or started something else.
Something. So good practice probably is still to start with one first, see the effect, and then add another or escalate to a higher percentage or twice a day or whatever. Uh, any other questions? Otherwise, we can wind up.
Uh,
I think Mona has
your
some.
voice is not coming, madam.
I said Mona has some concluding remarks. I'm sitting really close to my laptop, but
Yeah, but your voice comes and goes, ma'am.
I don't know. I can see my face right there in.
No, your video is clear.
I think Dr. Mona has some concluding remarks, and then
So it was a very interesting discussion. Great points by Dr. Jitendra and Dr. Sumita, and excellent cases by Dr. Akshay and Dr. Akila. And we had a good discussion also. So in the end, like in every power, I put everything together to give a summary, although I'm not a pediatric ophthalmologist. So the best prescription for myopia is just not found in the spectacle shop. It's a whole new lifestyle. And to manage the new generation, which sees pixels better than parks, we need many strategies. The first, of course, is the low dose atropine. And the dose is interesting, usually once a day, but you can prescribe it twice a day so that they put it once a day. Or you can even try 1% twice a month. One discussion we had was on 0.05%, but in resistant cases and in younger cases, good to avoid in uh, teenagers as they may be symptomatic, and always good to call back the patient after 3 weeks to assess, and good to assess the pupil size to know how the child is responding. And adherence to medication and follow up are very familiar terms, and I I am sympathize and totally understand the pain, because all this can lead to progression. But I wish we in glaucoma had Ortho K to bring back the nerve. You are lucky, even though expensive. Ortho K looks like magic to me. Totally worth the money, but of course, infection, and again, it's difficult, but challenges. But definitely worth an option. And like steroid analogy, once the patient is stable, you can taper it, and there are many ways of tapering, as both Dr. Jitendra and Dr. Sumita have different ways, and both work well. But rebound is bound to happen. So you can treat it by giving the myopia correcting glasses during that time to take care of it. Uh, Other things which you can see are asymmetric progression, but there's very scant literature to know why it occurs. Added villain is the IXT, and if it's there, atropine works better as it stimulates the fusional amplitude, and you may have esophoria also. Um, Additionally, two more villains are anisometropia and amblyopia, which you may need to manage. But to me, the magic treatment was the Ortho K. And there is a lot of challenges in treating myopia, and it requires a lot of teamwork to do that. And I wish you all the best.
Not you did an excellent summary for somebody who is a glaucoma specialist and not a pediatric ophthalmologist. Well done.
So the
She
word
always does. She always does.
Yeah, so I think nobody listens to Powwow anymore. They can just join in last 5 minutes and listen to you. That's about it.
That's what Dr. Saraf did. I think Dr. Pradeep Saraf joined just for the summary.
Mona's remarks. Anyway, thank you, Jitendra. Thank you
you
for
so much,
taking
ma'am.
Very
time out
nice
of your.
discussion. Lot of learning points. Amazing discussion and cases. Thank you.
Thank you so much, ma'am.
And thank you for taking the busy time out of your busy campaigning.
Not at all, ma'am. There's no campaigning going. There should be more.
Thank you, sir. Thank you for your inputs, and thanks to Sumita ma'am.
Yeah,
Thank
thank
you,
you.
sir.
Thank you, and
Thank
see
you,
you
ma'am.
next month
Yeah, see you
Thank
next
you.
for the
Good
next
night. Good
hour.
night.
Good night.